right, so today we're going to do something a little bit different. We are going to practice cracking a clinical case instead of reviewing pathophys like we usually do. So we're going to go to medagogy.org and we're going to sign in with Google. Okay, now we're signed in with our Google account. We're going to click Get Started, the internal medicine course, and we're going to use the free trial. And let's do a case of confusion because that's a pretty tricky differential that's quite broad, and it might be fun to practice taking a history for that. So we see actually we have a 35-year-old who's presenting with not just confusion, but also fatigue. Now I'm still going to probably use confusion as the main symptom that I'm going to work off because it's a little more specific than fatigue. And so let's start by just getting a little bit more information about this. How long have your symptoms been going on? And it looks like about 1 week. Tell me more about confusion, because that could mean a lot of different things. Okay, increasingly weak. It's not exactly confusion, but also difficulty concentrating and difficulty performing daily tasks. So that helps us a little bit. And in the back of my mind, I'm already kind of using a bit of a framework for altered mental status, which is MIST, M-I-S-T. If you don't know that one, definitely worth looking up. The M is metabolic, so metabolic causes of altered mental status like a high or low sodium, glucose abnormalities. The I is for infection, which could be a central nervous system infection like encephalitis or meningitis, or just a systemic infection. And sort of the toxic effects of that can cause altered mental status. S is structural, like a hemorrhage, and T is toxin, things like illicit drugs or medication side effects. So that's a really, really broad list, and hopefully with a little more history we can narrow it down, but it's kind of good to have in the back of your mind in case you're hitting a wall. So I'm going to get a little more history. I'm going to ask about headache because with confusion, I want to know if something else is going on up there. Okay, severe headaches. So kind of interesting that the patient didn't actually present with the headaches. So let's try to understand. So she does have migraines. Does this feel like your migraine? No, this feels different. It's more severe. Okay, so maybe we're actually dealing with something different. And so if this really is a new different headache, then in that differential we talked about, the MIST differential, I think I'm leaning towards the I and the S, infection and structural. Those are probably more likely to cause a headache. Let's keep getting some more history. Any fever or chills? Okay, slight fever subjectively. We'll check some vitals later. Maybe that's pointing me a little more towards infection. So we mentioned meningitis, so let's get some history there. No neck pain, no stiffness. And at this point, I'm just gonna keep doing a bit of a review of systems just to make sure we're not missing anything. Shortness of breath. Okay, so we do have some shortness of breath. That's interesting. No abdominal pain. Other kind of common symptoms we'll ask about. No nausea or vomiting. And then we could ask about skin changes because we're concerned about infection. All right, so we have small, round, red and purple spots on the skin that don't fade when pressed. So in other words, non-blanching. And they're starting in the legs and then spreading. That sounds maybe like a petechial or a purpuric rash. We'll have to look at that more on exam. That definitely changes my differential. That's bringing to mind some infectious causes like endocarditis, Rocky Mountain spotted fever. I should really probably ask about any travel. No recent travel. Where do we live, actually? What state? California, okay. So we can see the chatbot's a little bit buggy here, needs some tweaking. But California, I don't believe there's any Rocky Mountain spotted fever there. So other things that the petechial rash is making me think of, maybe it's some vascular conditions, thrombocytopenia, which itself could be caused by all kinds of infections. And okay, so let's round this out. Any past medical history, just to make sure we're not missing some chronic conditions that are super related here. Okay, we already knew about the migraines. Any medications that could contribute to confusion? No, don't see any there. Any substance use? Okay. All right, so at this point, I think we have a decent history. Now, we might want to go back, but we can at least now start getting some physical exam. I always like to start with vitals to see if there's anything that sticks out, and here we definitely want to know about fever, which does not seem to be there. And otherwise, the vitals are not too concerning. Borderline high heart rate, but not too abnormal. So I'm going to just start going down from head to toe. Curious about cranial nerves, especially with the confusion. And it looks like it's pretty normal. Now she denied neck pain, but let's check nuchal rigidity on our exam. Okay, neck is supple. I'm a little less worried about a meningitis now. Examine oral mucosa. Okay, interesting. So mild bleeding of the gums. Now I'm realizing that's something we probably could have asked on history. Once we saw the petechial rash, we could have asked if the patient was having some bleeding. And that could help us distinguish between something like a thrombocytopenia causing the petechial rash, in which case you might also have some bleeding, versus endocarditis or other causes like that, in which case you might not. So we do have some bleeding. Let's keep doing our standard exam. Listen to heart sounds. Fairly normal. Listen to lung sounds. Now remember, she had the shortness of breath. Mild wheezing. Interesting. Okay. Palpate the abdomen. Okay. And finally, I'm really curious to see the rash that she mentioned. And indeed, they're non-blanching macules. How big are the macules? Okay, 1 to 2 centimeters. That's actually pretty big. That's more purpuric than petechial. Petechial is usually less than 3 millimeters or so, but in general, you can have similar pathophysiology underlying either one, so this isn't changing my differential dramatically. But for the sake of correctness, we would probably call this rash purpuric. So let's go on to our studies, and now I'm just going to get some routine labs to start with, and then we can go back to revisit our differential and think about where we stand. So BMP, the real thing that's jumping out to me here is the creatinine, and while it's only just barely above the upper limit of normal, this is a 35-year-old female, and I really wouldn't expect that. And indeed, so that creatinine 1.3 corresponds to an estimated GFR of 55, which is definitely not normal for a 35-year-old woman. CBC, okay, no elevated white count. That was one of the big things I wanted to see for infection. Other than that, I'm seeing pretty significant anemia to 9.2. And then, wow, okay, the real thing jumping out here is the platelet count. So we have a platelet count of 15,000. That's dramatically low, and the differential broadly, when you're looking at a thrombocytopenia, is going to be things that cause decreased production versus things that cause increased consumption. Given the kind of acuity of this presentation, I'm leaning towards increased consumption, but it's not out of the question that maybe this patient had, let's say, a chronic decreased production of platelets that's led to severe thrombocytopenia, and it led to an acute presentation like a brain bleed or something like that that's causing the confusion, for example. But yeah, I'm leaning towards more consumption of the platelets, and that combined with the low hemoglobin is making me think about a microangiopathic hemolytic anemia. And so I'm curious to check an LDH, which is indeed elevated. And then I'm also going to want to look at the smear And it shows schistocytes. Okay, so that kind of confirms my leaning towards the microangiopathic hemolytic anemia. And I can think of a few things off the top of my head there. So DIC can certainly cause that, and so we should check coags. Okay, coags are normal, so it's not DIC. There's HELP syndrome in a 35-year-old woman, but it's usually the third trimester of pregnancy. Now, it's occurring to me that I didn't even ask if she's pregnant, which I probably should have. But let's go ahead and test for pregnancy. Okay, test is not available. We can assume that she's not pregnant. And then, let's see, HUS and TTP. And so actually, now that I'm thinking about it, TTP is a pretty good candidate here, and I think we actually have the entire pentad of symptoms, which would be fever, at least subjectively, we didn't measure one, anemia, thrombocytopenia, renal dysfunction, and neurologic symptoms. So that seems like a pretty good fit, and I believe the confirmatory test there is ADAM-TS13 activity. And it comes back less than 10%. Obviously, in real life, this would take a while to come back, but we have the luxury of immediate results here. And this really confirms a diagnosis of TTP. So I'm ready to go ahead and solve the case. Let's see if we got it right. We did indeed get it right. For management, I believe it's plasmapheresis. Indeed. And I see the bot is actually being kind to me here because technically, plasmapheresis and plasma exchange are slightly different. In plasmapheresis, you just remove a bunch of plasma. In plasma exchange, you remove a bunch of plasma, and then you put back normal plasma. And for TTP, you're really going to want plasma exchange because you want to get rid of the antibodies that are causing the disease with the plasmapheresis, but then you want to return all the normal healthy stuff that the patient needs, including the actual ADAM-TS13 that we just saw is low. Anything else? I believe you can treat with steroids as well. And that's about all that I remember. So let's see what kind of feedback we get here. Always important to consider rituximab. Great. Transfusion, yep, I didn't mention that. The patient did not need them for the hemoglobin. And this is a great point. So we want to make sure to avoid platelet transfusions for TTP unless there's severe bleeding, because they can worsen the thrombotic complications, of which this patient already has a lot. So that's the case. Let me know if this was useful or interesting. We can do more cases in the future. We went super fast here, so let me know if you want me to slow down a bit and more carefully update the differential, or if you have any other feedback.